I was just at a meeting at the ICPC in Jamaica where Ian Thompson presented a lot of the latest extracted data from the PCPT, and I'll comment on it. I didn't have a chance to incorporate it into the slides. I just got back. But I can comment on some of the PSA data that he presented, as well as some of the grade issues from PCPT if we have time. But this is I'm going to take you through a storyline here to try to appreciate prostate cancer from a natural history or biological behavior point of view. And at the end of the day, it really comes down in 2005 to the point where we're still practicing the science of the art of medicine, in that we don't have the numbers and the answers that we really wish we had today. So obviously we all know these numbers, that prostate cancer continues to be a significant public health issue around the world, particularly in North America, where this year 260,000 new cases will be diagnosed and 35,000 men will die. So that's not an insignificant number of deaths. It compares about the same to breast cancer in the opposite gender. And across North America, particularly in the States, the lifetime probability is now 17.8%, actually, not 16. So it's about 1 in 6 still lifetime probability. That means a 50-year-old man has a lifetime, and the rest of his life will have a 17.8% or 1 in 6 chance of being diagnosed of prostate cancer. And the other numbers are well known to you. 33% of all new male cancer deaths are cases most common, and it's continuing to be the second leading cause of male cancer deaths behind lung cancer. Perhaps most importantly, and something that's often not brought to light or discussed in seminars and sessions and in debates, is the issue of the degree of morbidity from this disease. We are talking repeatedly about incidence and mortality, but before mortality, prostate cancer, just like many other cancers that spread to bone and disrupt the local organ system, can cause a huge amount of morbidity, and that is lost in the statistics. It uses a lot of resource, and it's a huge personal loss, both psychologically and physically, to patients and their loved ones. So within that framework, let me just take you through a couple of concepts of natural history. What does natural history mean? It can be interpreted as histological development, the natural history from normal to cancer, or a clinical definition, a clinical progression from a single cell to metastatic disease and death. And I'll comment on biological significance and clinical relevance. So histologically, it would be nice if this is all we had to deal with prostate cancer. Just a normal cell, and there's all kinds of understanding. It doesn't show up well, but I'm not intending to go through all of the different biological, genotypic, and other molecular changes that occur. But one thing that is becoming very popular today is the concept of an inflammatory basis to prostate cancer. And inflammation in the pelvis, as you know, may be a lot more than what we've appreciated in the past with all three diseases of the prostate, as well as chronic pelvic pain disorder. It may be neuropathic pain, it may be inflammatory issues that are actually underlying all of these disease processes. But it goes from PIA through PIN and then into invasive adenocarcinoma, which is localized and then metastatic. So it would be nice if it progressed in that way. However, we know that prostate cancer is heterogeneous, and in any given prostate, you can get all kinds of grades and looks of the disease. It doesn't show very well on that slide, but you can see that within one prostate section, you have everything ranging from 4 grades of PIN right out to Gleason 7 disease. So if there is this type of histological progression, it doesn't follow any particular order. It just seems to develop within each cell at its own good time and pace. And so within any prostate, you can have quite a variety. The other issue with prostate cancer is we know now that it starts very early on in life. So even men in their 20s, and this is the famous Detroit autopsy series, even men in their 20s have an incidence of PIN and invasive carcinoma. And obviously the older men get, the more likely they will be found to have at least some prostate cancer. Much of this cancer is so-called latent, indolent, incidental, whatever you want to call it. But a lot of this cancer is also invasive and aggressive and will lead to the 35,000 deaths a year.
What's the ethnic sort of makeup of that?
Mostly young Detroit males. Killed in their 20s and 30s.
What's he talking about?
Huh? Hey?
What's he talking about?
Yeah, man. I just came back from Okay. The other issue is we're into the baby boomers. My generation, the baby boomer generation, is now getting into their 50s and 60s. And so we're going to see a lot more of this cancer because we're living longer. As long as we don't take vitamin E, we'll probably do well. And so as time goes on, by 2010, you can see the numbers of men, and certainly by 2050, the numbers of men in the millions here that will reach age 65 plus is growing exponentially. What about clinical progression and the natural history from that point of view? Well, we know again that generally prostate cancer begins as a localized single cell and grows through metastasis and hormone refractory to death. At this point in the progression in the natural history, this bar here is pretty thick. I think there's one more. And we see many of these cancers will be indolent, and men will die of other causes. But as you progress through the natural history and the disease becomes more aggressive and more significant, less men die of other causes, and death from prostate cancer increases. So that's just another way of looking at natural history. Finally, the biological significance and clinical relevance issue. We talk about not every prostate cancer being aggressive and leading to mortality. We discuss the fact that it's so highly prevalent in the population, the male population. That's fine. One of our goals is to understand and to be able to predict the difference between biological significant tumor and insignificant tumor. A biologically significant tumor is one destined to cause morbidity or mortality. However, every cancer is clinically relevant to the patient and his family, that once he's told he has a cancer, that causes anxiety, it leads and may lead to treatment with the potential for treatment-related morbidity. And so I'm going to be addressing this in great detail in a few minutes. And I use this analogy quite often with my patients. Those residents who have been in my clinic have heard me describe to patients how prostate cancer behaves similar in an analogy to the barnyard. This actually was first described by a fellow named Fisher for breast cancer many years ago. But it really does reflect and helps patients understand what we're talking about when we say that not all cancers behave the same. That, it's a cancer, but it's not a cancer. And you just sort of explain that some cancers are like turtles, some like bunny rabbits, and some like birds. And when you walk into the barnyard and disrupt the barnyard, the turtle is just going to crawl around a little bit and may eventually find its way around, but it's probably not going to do much damage. If it's a bird, it'll likely fly away pretty quickly before you can catch it. And the bunny rabbit will just bounce around, but if you don't do something pretty soon, it will find its way out. Patients understand that, but then at the end of the day, this is the way we understand it. It's still confusing. We have a long way to go to be able to predict where we are with prostate cancer in any given case, and it's led to an issue here which I'd like to review in some detail. The SEER data, SEER is a epidemiology register in the States, represents about 18% of the American population. And this is their data that they published a couple of years ago, showing how I put the line here into the pre and post PSA era, but prior to PSA, the incidence of prostate cancer shown in blue in the Caucasians and in yellow in Afro-Americans was very gradually increasing with time. When PSA was introduced, it became a natural experiment in the United States. It wasn't truly a screening, but more and more men started to have their PSA done, so more and more cancers were detected. And there was a culling here, sort of a harvesting of a large number of prostate cancers, so there was a real peak in the early 90s. And now it's settled back down. Now that culling effect is over, it's settled back down, and the slope of the curves are about the same as they were before. I'll talk about the mortality in more detail in a moment. So prostate cancer today in 2005 is much different than it was 20 years ago in the early 1980s. And it's because of the ways we've changed our diagnostics and also the increase in the diagnostic activity that now we're seeing prostate cancer at an earlier age in general, earlier stages, in decreased volumes, and with increased treatment rates. See, Jason, I knew that this wouldn't come through. Okay. This is what fishing for prostate cancer in the pre-PSA era was. This just showed a boat with one fisherman and one fishing rod in it. and you sort of picked up the cases one at a time. In the post-PSA era, this picture was a trawler out in the ocean, and you're picking up, harvesting large numbers of cancers all at the same time because of PSA. That's nice if every single one of those cancers was an aggressive tumor, there were no such thing as an indolent prostate cancer, and we could prove that we can save millions of lives by doing that. Unfortunately, that's not the case. And what's happened is it's resulted in a disconnect. This is in the United States, but it applies to Canada as well. The incidence bar here and the mortality bar. There's a huge difference between incidence and mortality in prostate cancer. Look down here at pancreas. They're almost overlapping. And if we look at the actual chart again, the SEER chart that I just showed you, I suspect that what happened back in the 80s is that we were underdiagnosing prostate cancer. We were only picking them up on DRE. Even with acid phosphatase, we weren't picking up a lot of prostate cancer. So most of these guys were more advanced. We weren't using ultrasound-guided biopsies. Today, with ultrasound-guided biopsies and PSA, we are diagnosing and probably over-treating. Once again, the numbers here, and if we look at the deaths per cases, about 1 in 5, 21%, comparable to breast cancer, where they have a similar disconnect. Because of screening, they're picking up a lot of cancers that women are not dying of. Now, we don't know why that is. It may reflect better treatment. It may reflect just the biology of the disease. But compare it to lung cancer, where there's still an 87% of new cases dying. So we have the dilemma today that we had when Willett Whitmore described it 30 years ago. We really haven't moved that much farther forward from Willett's questions of is cure of prostate cancer possible when it is necessary? That is, the more advanced disease, the aggressive disease. Is it necessary when it's possible? The patient with a very small focus of tumor. We know we can cure those men, but is it necessary? So that dilemma continues to trouble us, leads to people establishing their careers on debating the issues of diagnosis and screening. I just wanted to touch on look at it from a couple of points of view of decreasing overdiagnosis or decreasing overtreatment. So as a result of this U.S. experiment with PSA over the last 20 years, as mentioned, there's been a stage migration. At the same time, our local therapies are getting better, radiation and surgery. We've seen a dramatic fall in metastatic disease and death rates falling in multiple health settings. So if we look at stage migration, this is from the American Army database. The 10 years from 88 to 98, you can see a significant drop here in patients with clinically detectable disease with nodules, and the number of patients with T1C's disease is escalating here at a dramatic rate over those 10 years. So PSA was harvesting the patients at a lower clinical stage. There was a stage migration. The captured national database shows the same thing. The T1 lesions in yellow increasing with time. And one other study, this is from the Baylor group when Scardino was still there, and again we can see the number of patients with T1C disease rising dramatically here in the yellow. So there's no question that there's been a stage migration. I think we've all seen that in our own clinical practices. Our therapies have improved. If we look at radical prostatectomy result data, and I just took data from a number of series from different years, and you can see this is biochemical relapse-free survival just in the 3 different timelines or time periods. The results are markedly improved with time. I think that reflects both the fact that we're detecting the disease earlier on and that we know how to do a radical prostatectomy better. The anatomical approach. This just shows the same thing. This is from D'Amico, and again, it's putting together a bunch of publications. D'Amico, we owe D'Amico thanks for making us think about risk stratification, the low, intermediate, and high risk. And this is how we approach our patients today, the turtle, the bunny rabbit, and the bird, if you will. He just took the farm analogy and put some numbers to it. And finally, the complication rates over time shown here, that from the early 60s to the 90s, this is the rate of sexual dysfunction following treatment has declined. Obviously, it's very much operator dependent. But in general, patients are doing much better with the treatments, again, be it surgery, and I didn't put up the data for radiation, but same thing with radiation. As the technique and the technology improves over the years, the complications from the treatment have diminished significantly. We've seen a dramatic fall in metastatic disease, again shown here quite clearly. And again, when was the last time any of you saw a guy come in on crutches with metastatic disease? Once in a while, but it's not like we used to see 20 years ago when it was pretty common. Finally, the death rates continue to fall, and there's a whole bunch of series where it's been documented, shown here. This is the SEER data that Bob Stevenson published in 2002, and it's again showing the percentage decline in mortality, and by 1999 it was 22%. It's now about 26% decrease in mortality over the last 10 to 12 years. So there's been an overall decline in mortality, but we don't know what to attribute that to, whether it's early diagnosis, whether it's better treatment, whether it's something in the air. We don't know. It's probably a mix of all things. I just want to bring out one issue about mortality figures, and that's something called attribution bias. This is showing the U.S., the mortality is just a blow-up on the scale here of U.S. prostate cancer mortality, and we see that it was increasing till about the mid-'80s when the PSA culling effect came in, and mortality has been dropping. Okay. However, there was the other thing that happened back in the mid-'80s here was a change in how death records were kept. Prior to that, if a man died of a cardiovascular event and he had terminal prostate cancer, he died of a cardiovascular event. His death was attributed to cardiac disease, not to prostate cancer. That changed, and today the death record will show the primary cause and other diseases that the individual had. So prostate cancer will come out. So that's called attribution bias. If that attribution bias hadn't taken effect, okay, because all of a sudden in the mid-'80s we had all these patients who now their death was being attributed to prostate cancer, so their mortality was going up. If that had been the case all along, and we had started this downward trend here before the change in death certificate, then I suspect that there probably would be even a larger drop in mortality from prostate cancer. So when you read about mortality rates, think about the attribution bias effect. I think it's a real effect and one that we don't want to overlook. And finally, Antonio's not here, but I always like to show the Mexico data when Antonio's around. That the PSA is not being applied across the board in Mexico, and the mortality goes up. Now, people will show you another curve, and that's the curves comparing U.S. and the UK and Wales. In UK and Wales, PSA screening is not very popular. And in fact, if you look at the incidence curves between the UK and the United States, they're what you expect. In the United States, they're up here. In the UK, they're down here. But the mortality is about the same from prostate cancer. So that continues to raise the issue of what are we doing with PSA. However, if you want to look for if you want to find it, you have to look for it. Okay? So how do we look for it? I mean, we have to find it because we still have 35,000 deaths a year in North America and many more across the world. So it still kills a lot of guys and it causes a lot of morbidity. So we still want to look for it. Unfortunately, PSA hasn't been great. In fact, it's been too good. It's picked up a lot of cases that are indolent. It does not differentiate tumor volume, as Stamy just recently showed us. It used to 20 years ago, but PSA today does not predict for tumor volume. And we know that PSA doesn't necessarily predict for grade. So PSA can pick up prostate cancer, but PSA alone cannot differentiate the turtles from the birds. So we definitely need a better marker. Okay, any points or questions? We have a long way to go on diagnosis yet and to try to understand it, but what we do know is that PSA is not perfect. It still remains the best biological marker in oncology, however, and we certainly cannot abandon PSA. We just have to learn how to use it better. What about overtreatment? I mentioned earlier that perhaps, in that curve, today we're overdiagnosing and probably overtreating. Well, why does overtreatment happen? Well, we don't have randomized trials yet of no treatment versus treatment and so forth. So we really can't determine the true efficacy of our interventions. So in the absence of a randomized study, we, as physicians, we want to do something for our patients. So we tend to fall onto the side of the fence that says do something for this patient. And we tend to recommend aggressive therapy because you can't go wrong. If you got a patient sitting there and he's anxious because you've just told him he has cancer, well, you can't go wrong. And if you treat him and if the disease progresses, you've done everything you could. And you say, sorry, Mother Nature beat us here. If the disease does not progress, if the natural biology of that disease was such that it wasn't going to kill this guy, well, you've cured the patient with your treatment and you're the hero. So you're in a win-win situation. And that's what's led to overtreatment. It continues to be an issue across the world, particularly south of the border. It's a little less so in Canada. And the two sides of the argument on this, when you talk to people about it, is you'll hear this, that every man who's 70 years old with metastatic prostate cancer used to be a 55-year-old or a 60-year-old with curable disease. So we have to prevent the metastatic disease. And this is true. It's true. But we don't know when we're facing that 55 or 60-year-old who's going to develop these metastases. And this is the issue. Prostate cancer is not the only cause of death in men. Okay? So the guy driving this car here probably had prostate cancer. But he didn't die of prostate cancer, okay?
That's attribution bias.
Attribution. So the oncological dilemma continues. And the greatest challenge to us continues to be able to develop a marker of some sort or a combination of markers, be them biological or histological or whatever, or a combination, so that we can identify the significant cases, the ones that the birds and the bunny rabbits, to intervene to prevent serious morbidity and mortality, even if it's years away, so we can prevent the morbidity later on. But we don't have a crystal ball. And that's where we have to fall back on the art of medicine. And really, you take population studies and you look at population health issues, but when it comes down to the guy across the desk from you in the office, it's one-on-one. It's individualization. Marty?
Sorry, if you overtreat, how could you be in a win-win circumstance if you have an incontinent, impotent patient sitting?
Because you've done everything possible and you've beaten the disease. Yeah, well.
I mean, he's not your friend. Doesn't matter how much you clear, he's not your friend.
But you've gotten rid of his cancer, and you go say, sorry about that incontinence, but you're free of cancer today. So individualizing, and the best what we can do today is look at the characteristics of the patient, the characteristics of the cancer, and try to individualize to the variety of treatment options. And you can probably add others to this today. And try to match up for that particular individual. This is where patient education is so important, where Joyce Davison's resource center comes in very handy. Patients need time. You can't just say to them in 5 minutes, outline, years and years of study and issues and controversies in 5 minutes. And some patients don't want to learn and other patients do. And Joyce has been studying this, and perhaps one day we'll have Joyce come and give us some of her data on patient education. But it really comes down to, at the end of the day, the individual has to be comfortable with the treatment that he selects. He and his spouse or family has to be comfortable with that. Otherwise, at the end, you'll be like Marty's patient he just described. If you haven't prepared the patient for all the potential outcomes, he's going to be a disappointed patient and he won't be your friend. So Marty, you just have to talk more to your patients. Selecting appropriate therapy.
I was talking about the guy that came to me from you.
Oh, that guy. Conservative approach. I wonder what happened to him.
There's just one, right?
Just the one. Okay. So when we select appropriate therapy, we can there's two schools of thought today. The more conservative and the more aggressive. So in the conservative group, that is, you don't treat as many patients, perhaps more of the surveillance approach. You're going to undertreat those who need to be treated, but hopefully you won't lose them. And I'm going to come back to this in great detail shortly. But you'll spare those who do not need to be treated, or at least you'll spare treatment for a while, or you'll defer treatment. In the aggressive approach, you're going to overtreat men who don't need to be treated because they're going to end up dying of something else. And in some cases, it's going to be futile treatment because it's a bird and it's metastatic and your primary treatment will fail because of the biology of the disease. So, you know, we continue to have this quandary, this dilemma, and it's not an easy thing. So with some of the outcomes that we look at when we try to decide on what the best treatment is for an individual, life expectancy, obviously you're going to treat a 50-year-old much different than an 80-year-old just because of sheer life expectancy. And this is Metlin's work from '99 that shows that nearly 1/3 of newly diagnosed patients are less than 64 years of age. Okay, so we're seeing more patients at an earlier age. And if we consider, well, what from a life years point of view, how many potential life years we can save, or how many would be lost, at age 55, somebody with a low-grade tumor, you're looking at a potential of 2 years of life years lost. If they have a higher-grade disease, more than 11 years. The older age patient has less potential, but there still are life years lost. I mean, if you tell a 75-year-old that he's going to lose 2 years of his life, that's significant when the clock is ticking and there aren't a whole lot of years left. 2 years is pretty significant to that 75-year-old. So we can even look at it from comorbidity point of view, and Albertson showed that comorbidity is probably as powerful a predictor of overall survival as tumor grade. And that's intuitive, and we understand that. And don't overlook patient preferences. This was from the Prostate Cancer Awareness Week data Dave Crawford published. And if you look, 45% of patients will tell you, these are younger patients, they'll place a higher premium on quality of life issues than on delaying disease progression. So, this is the patient that Marty just described, the incontinent, impotent man. Quality of life may play in much more importantly. And because we can't guarantee anything to patients, it makes it that much more of a difficult decision. What about outcome with respect to grade? There have been a number of studies listed here that have looked at tumor grade, and I'll just zip through them quickly because they all show the same thing, that the higher the Gleason score, the more likely the patient will die of cancer, of prostate cancer. You can see the red is all deaths, yellow is cancer deaths. Johansson's study here, again, the big difference between well-differentiated, moderately, and poorly differentiated, though the numbers are small in the poorly differentiated group. Johansson recently, last year, published an update of his series, and it shows it a little bit more clearly that patients with higher grade tumors have a much worse survival than patients with low-grade tumors. Again, the turtle, the bunny, rabbit, and the bird. Pretty clear. Jerry Chodak put together a bunch of trials from around the world, databases, and found, again, the same thing. Poorly differentiated. The grade is a significant predictor of survival. This is Liu Yao's group from Medicare review, and Albertson showed a 10 times increased mortality between low grade and high grade. Albertson published these nomograms back in the late 90s. Now this was based on DRE diagnosed prostate cancer, so it doesn't reflect today's population of patients. But what it does show, and this is a risk analysis showing that men, this is age group down here, so 55, 60, 65, so forth, down these columns, and the different grades of disease. The red indicates death from prostate cancer, and the gray is death from other causes. So you can see that in a young man with low-grade disease, the chances of dying of prostate cancer are pretty minimal. But when you get down to the high-grade disease, Gleason's 8 to 10, the chances of dying of prostate cancer far exceed the death causes from other. And the other point taken here is even men who are in their 70s, you can see a lot of them will die of prostate cancer compared to all-cause death. I'll just pause for a second. So we thought it all made sense with respect to grade, and that grade could really predict for us, and that maybe that was the way to go. We'll use PSA, it'll pick up cancers, and then we can look at the grade and decide whether or not patients need to be treated. And that's led us to the path on the conservative side of developing active surveillance, meaning we don't have to treat everybody. We have predictors that will help guide us into who needs to be treated right away, who perhaps will need delayed treatment, and who may never need treatment. We look at all those outcomes that I just went over. And the hypothesis then of active surveillance is that you can delay curative therapy to a subset of patients while they may have rapid progression, but you're not going to lose out. In other words, you can offer them delayed therapy without them dying of their disease if you're following them closely enough. But the majority who will be favorable risk patients can be managed with observation for a number of years, and that will increase their quality of life, which is, of course, the most important issue for individuals. This is all based on a critical assumption, and that is that our predictors of natural history or biological behavior or whatever you want to call it can accurately separate out the indolent, incidental cancer from the aggressive one. Happens to be the majority from the minority. But we need a better marker. So we're assuming when we take on active surveillance that we know that the patient that we are surveying will not be lost, that we won't lose that window of opportunity to cure him. I'm sorry that the other one didn't show up here, so I'll just pass through that. Oh, there it is. Okay. And this is what I'm talking about. So here's a patient with clinically detected cancer, and when you look at the slices, you can see how much cancer there is, but it's all kinds of grades. This is just to show that you know, if your needle went through here and here, you're going to get two different grades. This is an indolent cancer. You may have picked up the cancer with your needle, operated on this guy, but I doubt that this cancer was going to kill him. So we need a way of being able to differentiate those two scenarios. And as I keep saying, we don't have that yet. And I hope we get it. And some people are very skeptical. They're not sure that we'll ever find that magic mark. But I think that we will. Certainly by genotyping tumors, I think we're going to learn a lot more and get closer to being able to predict. Watchful waiting, expectant management, active surveillance, these are all terms that have been used to describe this process of watching the patient. I think the best term today is active surveillance with delayed or possible delayed intervention. Yogi Berra actually started it years ago. He said you can observe a lot just by watching. And there are a number of studies. There's another study I just came across from Japan, which I'll have to add to this list. So these are all phase 2 studies. There are no randomized studies yet looking at active surveillance. Only in the States, there seems to be a different attitude amongst patients. Still, if you look at the capture database, only 10% of individuals in the United States elect watchful waiting when given the option. 90% of patients go on to some form of therapy. And if we look at the profile of patients, this was at the AUA in 2000, I think it's published now. 8.2% selective surveillance. They tended to be older men, Caucasians, with lower PSAs, clinically organ confined, and with lower Gleason scores. So you can see that these characteristics, the surgeon or the oncologist would be much more comfortable as well in offering watchful waiting to this kind of a man. And the individual would be happy and comfortable, particularly over 75 years of age. However, within the capture database, the likelihood of secondary treatment within 5 years was over 50%. Okay? So you started active surveillance, but within 5 years, half of the people went on to some form of therapy. Remember that 52%. This is the Toronto series, Laurie Klotz's work at Sunnybrook, looking at doubling times. I mentioned that one of the assumptions of active surveillance is that PSA doubling or PSA velocity was an accurate way of monitoring these patients. What this fleshes out is that there's a huge variation from less than 1 month to less than 1 year to greater than 30 years doubling times. That's what you see in these patients. And they took a cutoff, and Laurie feels that about 3 years, if you have a doubling time, if you take doubling time of less than 3 years or greater than 3 years as your differentiation, as a trigger for treatment, that you're probably not going to be too far off. And using that trigger, this is from his series of the actuarial probability of being progression-free 63% at 65% at 5 years. So in the Toronto series, 35% of patients went on to invasive therapy of some sort within 5 years. Okay, I just mentioned in the capture database it was 52%. In Toronto, it was 35%. With this, they didn't lose anybody. 99% prostate cancer survival at 8 years. They had 2 prostate cancer deaths. We reviewed our data here up to 2000, and I'm bringing it up to date this summer, I hope to. We've got well over 100 patients now in active surveillance at the Prostate Center, and the group at the BCCA have probably close to 300 patients, Scott. And we're going to be with Mike McKenzie, so we're going to bring the two together, and the two databases together. I think it will be interesting to see whether or not there are differences in demographics, trigger points, outcomes, and so forth when looking at a radiation oncology series versus a surgeon series. And we'll pull the data. But this is what we had up to 2000 when we last reviewed it. Mean age 69 years, and mean follow-up of over 5 years. Minimum follow-up of 1 year. And our doubling time data look about the same as we saw with Laurie's data, that it varies. We didn't have anybody in less than 1 year doubling time. And we actually had quite a number of patients. The yellow shows patients who remain in watchful waiting. Quite a number of them actually had decreasing PSAs. And I guess a lot of you have seen that as well. You get a guy who comes in with a PSA of 5, you biopsy him, and then you monitor him, and 6 months later his PSA is 3. It's actually gone down. So something else had triggered the PSA rise, be it a small infarct in the prostate, some prostatitis or whatever, riding a bike, whatever. Something triggered his PSA to go up. You biopsy him, and then it goes down to his true baseline 6 months later. And so that's not uncommon. And again, very common to see patients with doubling times that far exceed 4 years. And in our series, 1/3 of patients went on to other therapy within 5 years. Okay, again, so the Toronto series was 35%, ours is 33%. The
33% that went on to hormonal therapy.
No, they went on to some other form of therapy.
Oh, well, could we see that pie graph again?
Yeah, hormone therapy is 13%, yeah.
Does that mean they had, while you were surveying them, without metastasis?
No, that was just the patient's choice.
And he still had
Older man, they wanted to have hormone therapy, probably intermittent therapy.
Okay.
Yeah. They didn't want to have radiation or surgery. Those 8. I'd have to go back and look at the 8 patients and to answer accurately, but my recollection is that it was just patient choice on treatment. We learned a lot from the Memorial Sloan Kettering series, and there's one very important point that we learned from the Memorial series for watchful waiting. They reported on 88 patients, and interesting that 5 years, their progression-free probability was 64%. But if you look at their treatment-free probability at 5 years, it was 56%. So 8% of patients, the difference between 64 and 56, did not progress but were treated, meaning that it was patient-triggered. Patients got itchy. They decided, I've had enough waiting. I'm worried about this time bomb I'm sitting on, and they elected for treatment. But the actual progression-free probability was 64. So they had 44% of patients at 5 years go on to other forms of therapy. This shows their PSA doubling times, same kind of a pattern. It's interesting that there's quite a wide spread. So it really makes you think, how accurate is PSA doubling time, and what should that trigger point be? Is it 24 months or is it 36 months, as Laurie suggests from Toronto? I'm not sure what the trigger point of a PSA doubling time should be. In their univariate analysis of their data, they showed that the top 3 had p-values of significance, positive second biopsy, PSA at baseline, and PSA density. In fact, one of the things that Ian Thompson is teaching us now from the PCPT data is that a single reading of PSA is probably more important than the PSA velocity. And this is probably the most important point that I took out of the MSK series, and that is that you have to rebiopsy the patients. Obviously, you can't just go on the first biopsy because you don't know if it's the tip of an iceberg or the needle in the haystack. Remember those 2 slides I showed you? You don't know what you're dealing with, so you repeat the biopsy. You do another 8 cores or 12 cores or whatever. And in Memorial, they showed that if the second biopsy was negative, look at the progression rates. It's like a flat curve. Nobody progresses. But if the second biopsy is positive, these patients are going to progress pretty quickly within the next 5 years. Yes, Lauren?
When I walked away from urology, PSA density was considered highly suspect because the quality of measuring the size of the prostate with the ultrasound equipment of the day. Is the PSA density in 2005 an accurate measurement?
No, nobody uses PSA density anymore. That was in the New York series. They looked at it. But it's not being used today. It's not being used today because Stamey has shown clearly in his scattergrams over the last 20 years that PSA does not reflect tumor volume, that it's BPH that's driving the PSA more than anything else.
So that statement is
in fact, one slide I don't have up here is talking about subtracted PSA. This is a new concept in PSA that D'Amico introduced, and it's where you subtract, you take the baseline PSA and you subtract it from your total because it represents the BPH component, and then you track it. So if the PSA, if there's a cancer in there, the rate of the subtracted PSA is going to increase much faster. If it's mostly BPH and no cancer in there, it won't change very much. And so you look at the doubling time of subtracted PSA in patients who have larger prostate glands.
In patella surgery, did he biopsy everybody, or were they selected in some way?
Yeah, it looks like there were about 18 patients probably refused to have second biopsy. I'm not sure what that. I have to go back and look. I don't remember. Okay. This is the. Oh, sorry.
Do you just do one repeat biopsy, or 3 years?
There's no established protocol. I'll describe a randomized study that's going to be done shortly that has established a protocol, but doesn't mean it's the right protocol. Okay. In my own practice, I do a biopsy at sometime within 3 months. Doesn't necessarily have to be at 3 months, but I don't like to wait longer than 3 months. Often it'll be just a few weeks later, and then at 1 year, and I just monitor the PSA and DRE. Perhaps at 3 years I might do another biopsy, that kind of thing. But it's a little bit random. There isn't a set protocol. No, I don't know if anybody could really tell you what the right way to do it is. Scott. Yeah, the START. I'll come back to that because the START study is based on their protocol. Yeah. So they call it temporary deferred therapy in the American Army. Judd Moll gave me this data. They had 313 patients with localized lower intermediate risk cancer, and at 4 years, only 27% of these soldiers still were on watchful waiting. Now that might reflect, I don't know what it reflects in the American Army, but they get on with things right away. So laser-guided prostatectomies occurred in 73% of these soldiers. Zeitman from Boston, 43% at 5 years and 26% at 7 years remain untreated. So 57% triggered treatment within 5 years. UCSF series, they didn't comment in this series on what their treatment rate was at 5 years. But if we look at all of this, a couple of them were 3 years, but somewhere up to 5 years, there seems to be a little bit difference between Americans and Canadians. In the U.S. sites, it ranges anywhere from 31 to 73% intervention at 5 years. In Canada, it's closer to about 30. The 28% is the Armin Aprikian series, which I didn't show in Montreal. Ours was 35% and Toronto was 33%. So in Canada, it's all around a third of patients go on, whereas in the States, up to 3/4 of patients go on. I've talked about the uncertainties and why we don't know enough about doubling time and whether or not PSA velocity or acceleration is a good enough trigger or monitoring method. We don't know how often we should be checking PSA and so on and so forth. So there's a whole lot of uncertainties. And again, this is why people argue against watchful waiting, that you're going to miss that window of opportunity and the patient's going to go from organ-confined cancer to metastatic disease. And then the more conservative people say, well, why not just wait? Time will help us here. And basically it comes down to a randomized trial that needs to be done. Without a randomized trial, we are not going to ever get an answer of watchful waiting versus intervention. And so this study should be started pretty soon. It's called the START trial. I'm trying to remember what START stands for. I can't remember what START stands for. But it's basically active surveillance with the selected delayed therapy versus immediate therapy. And in this one here, patients with low risk to intermediate risk disease will be randomized to the two arms, and they'll be biopsied again at 3 months, at 12 months, at 2 years, and 5 years, and they'll have their PSA checked every 3 months in the first 2 years, and then every 6 months thereafter. So that's the protocol that is basically in Toronto. Laurie Klotz is the PI on this study, and he's been going around, and it's going to be an intergroup study. CalGB has bought in. I think it's now just being reviewed down south, and hopefully will be up and running pretty soon. The protocol is written. So just to sum up, patients hear the word cancer, they want definitive therapy. The word cancer obviously evokes a response. It's a clinically relevant word. It's the response in many cases is disproportionate to reality, the reality being it's a low-risk cancer that's unlikely going to impact on the man's life. And so it's a real communication challenge to us today, particularly in the absence of all the evidence that we need. And, without that real good crystal ball, it's a communication challenge to overcome that when we talk to the individual patients. But we met the challenge with stage T1A prostate cancer going back years ago when we did a lot more TURs and we diagnosed a lot of prostate cancers. Incidentally, on TUR, where less than 5% of the chips were well differentiated, those was called a T1A disease. We don't see a whole lot of T1As today because we don't do as many TURs and everybody's had PSA and biopsies. But in the days of T1A prostate cancer, though, we didn't, we used to operate on a lot of those guys and probably didn't need to. And I still have a number of those patients in my watchful waiting series who are like 20 years and are still showing no disease progression. And the number was 15% progress at 10 years. And today the consensus is that T1A is best managed with surveillance. And that's not just today, but that was even before Lauren abandoned urology. Okay. Walked away, sorry. So one thought today is perhaps we should talk about T1CA prostate cancer, which is based on systematic biopsies, more than equal to 12 cores, less than 1/3 of the cores involved, small volume, no Gleason pattern of high risk, and a low PSA. And let's call it a T1CA instead of a T1A, or instead of a T1C, because there's T1Cs and there's T1Cs. I mean, there's a T1C that has 8 cores positive, and there's a T1C with 1 microfocus. They're both called T1Cs, but you're going to treat them radically differently. And so why don't we start thinking in our minds about T1CAs and think about surveillance just like we did with T1As, and we certainly didn't lose a lot of patients by treating them that way. Instead of reading through all of these, I've basically said all of this stuff. Where are we with predicting outcome? Tons of papers. They just keep pouring out of the literature looking at all kinds of biological issues, molecular markers, histological issues, obesity, so on and so forth. Everybody's looking at it from every which way to try to see, is there some way of predicting outcome? Molecular density was looked at. I think the DNA structure of the tumor, the pattern is going to be able to differentiate the significant tumor from the indolent tumor. People looked at P53. This seemed to come and go. But this is really where it comes down to, I think, today, and where there's a lot of hope for the future, and that is the molecular diagnosis. You take the man, you biopsy his prostate, you take the tissue, you dissect it out, and you look at proteomics and look at the protein arrays and genomics at the gene microarray, and you get a pattern that's individual to that particular man's tumor, and plug it into a network, a neural network of some sort, into an omogram, and it'll tell you that based on this pattern, this man's tumor is unlikely to progress or is likely to progress. This is the holy grail of prostate cancer and probably the holy grail of all cancers today. If we had such a means of predicting of this type of a crystal ball, it would make our lives a lot easier. Taking it one step further to the patient who is undergoing treatment, there's a lot of work also looking at the molecular patterns in tumors and predicting responses to different chemotherapeutic agents. And we saw that in our neoadjuvant, just as an aside, our neoadjuvant docetaxel and buserelin study in our 80 patients that we treated. About 14 of those patients had a remarkable downstaging. 2 of them were P0, and the others didn't have much of an effect. And so there's definitely a difference in sensitivity between individuals. All of them had high-risk disease. I'm not starting again, Joel. MUC1 protein expression predicts recurrence. This is a protein that this was shown by a fellow down in Stanford named Lapointe, and it's just one example. If you look at this curve here, the green and the red are just showing you the different gene up and down regulations within this tumor. So MUC1 is shown there. And if we look at the pattern, patients who had MUC1 had a much lower recurrence-free survival. So it seemed to predict. So that's just one example of where we can go with molecular diagnosis. Von Eschenbach talks about the R7 paradigm. As you know, Andy is now has been the NCI chair, and he predicts that in 2015, the R7 paradigm will revolutionize healthcare. We'll be able to provide to the right patient and tumor the right intervention for the right reason, at the right location, at the right time, with the right outcome, monitored in real time. That is the Holy Grail, and we hope we can reach that point where in prostate cancer we'll be able to apply some sort of genetic testing or genotyping to men, identify men who are going to develop prostate cancer, and within that subgroup of men, be able to identify those for whom treatment will be necessary, those whose cancer can be prevented perhaps with diet or other drugs, and those for whom a medication diet or medication will prevent prostate cancer. So if we be able to apply these kinds of tests, just think about what we can do in the future. So I hope that sort of puts some understanding to the way at least I see natural history of prostate cancer today. It remains an art of medicine. Unfortunately, I wish we had these markers and we could predict in any given individual. It remains a challenge on a one-to-one basis. Reminder, the abstract deadline is coming up. I can't remember, when is it? It's April 4th. April 4th is the deadline for the Western Section meeting at the Bayshore, first week in August. So get your abstracts in. And thanks. That's it for this.